Our special guest today is Dr. James Crapo, who is the chairman of the board of the COPD Foundation. He's also the lead investigator for the COPDGene Project and a research pulmonologist at National Jewish Health in Denver, Colorado. Welcome, Dr. Crapo. It's great to have you join us today. We're looking forward to your presentation.
Thank you. Should I go ahead?
You should go ahead. You start anywhere. If you want to say hello and maybe introduce yourself just a little bit more.
I will, but let me share my screen first. And so
Thank you, sir.
This can people
welcome, Dr. Crapo.
Yeah, can you see my screen now?
Yes.
We do. Yes.
So yeah, I spent my life in academic medicine. I've 25 years at Duke University, and then now about more than 25 at National Jewish. And my major focus has been on COPD. And they asked me to come together and tell you a little bit about why it is so nice to have COPD and bronchiectasis in the same foundation and how they might relate. Now, I understand there's some really important differences, and I'm going to tell you what I'm learning about it from my perspective. I totally understand that in many elements of severe bronchiectasis, it's quite a different disease. So we'll come back to your questions about that. But I'd like to just tell you a little bit about it and be willing to answer any kind of questions. Now, the project that I've been responsible for the last 17 years is called COPDGene, and it's a project to study COPD. It's 10,000 people from across the country, as you can see, the red dots, were in this study, age 45 to 80, and we now are doing the 15-year follow-up of them. And I know that these were all cigarette smokers, and we did that on purpose because we wanted to see how that really stressful event caused this disease. And I know that many people with bronchiectasis don't share that exposure component. We can come back to that. But it's interesting, when we started COPD, this study, we actually excluded severe bronchiectasis because we recognized that it was, at that time, almost 20 years ago, it was viewed as a very different disease. And we're now looking at how they come together. So this cohort does not include anybody who had no bronchiectasis at the time they started. And what I want to just show you to begin with is when we study a patient, we have them do a spirometry and breathe out as fast as they can. And we put them, there's 10,000 dots on this page, which are the 10,000 people that we're studying. And people that can breathe out well and normal are thought to be in the upper left quadrant, right up here where it says normal. And this quadrant over here was thought 20 years ago to be restrictive lung disease. It was ignored for disease. And anything below the red line was considered a low breathing capacity and likely COPD. We'll come back to bronchiectasis on that. So what we did, after we'd done this study we had about 7, 8 years of data, we decided to start doing artificial intelligence on it. And what we used at that time was called principal components analysis. That's a form of artificial intelligence in which you put in your data and you ask whether or not your data shows any kind of correlations that we might find from a computer looking at it that we're not seeing well with our eyes. So it really is all the data goes in, but we're asking it specifically, what relationships does the computer find? And what we fed into this is this. We fed in a bunch of material that eventually starts showing emphysema axis, and also material that showed an airway axis. Now, and actually, around this peripheral curve are the things we fed the computer. We fed them the raw data. And the arrows pointing in and the strength of the arrow indicates what the computer came back with and said, hey, we find relationships here. That was done with artificial intelligence. And but it really came back and said there are two really prominent, actually it said there were 4 axes, but these are the 2 big ones that stood out. And one we called emphysema predominant, and one we called airway predominant. Now, what we used as an endpoint in this was survival or death. We looked at that and said, use these parameters to find out what correlates to really bad disease that might lead to death. And we found that there was an axis. This is the emphysema axis. And the top 20% of that had an increased hazard ratio for dying, about a 20 about a twofold or greater than twofold increase of dying. And all those were those were associated with what I had in the previous slide. They were associated with these kinds of parameters that deal with the chest X-rays or chest CT showing evidence of emphysema. But we went to the next axis, and that one had almost a 7 to 8-fold increased risk of death. But the correlation was not with emphysema. The correlation was back with these airway disease parameters that I showed previously with the big black lines here. So we looked at that and said, what's going on? And we said, let's graph it. Now, in blue, we graphed the people that had the high risk of dying with emphysema. And in red, we graphed the people with the highest risk of dying due to airway disease. And because there was such an increase across the whole curve, in green, we put in people with a 4 to 6-fold increased risk of dying from airway disease. And this is what we found. The computer showed this. These are the graphs. And it's interesting. Remember, this side, this corner up here is normal. All the blue dots, or the emphysema, go down this classic pathway. And then the red drops go this way. They're totally separated, which surprised us. This had never been seen or published before. Now, yellow means that they have both. They're both blue and red at the same time. So the really bad patients are down in the far left. The green is the intermediate airway disease, and it kind of falls between those two. But look at how it seems to be moving into this quadrant over here, which we named PRISM. That means preserved spirometry, but impaired FEV1 breathing. So this was a very interesting finding. Now, if I just combine the red and the green together for simplicity, it looks like this. And if you looked at mortality, the people in this quadrant over 7 years had about a 16% death rate. With the blue dots, it was about a 23% death rate, but with the red dots, it was 30%. And the really severe disease, which I hope nobody gets, but that was almost 2/3 of them had passed away in 7 years. So we started saying, wow, what's going on here? Can we understand this disease better? And but we wanted to start out with recognizing that there's an airway predominant disease that goes like this. And I hope you're all beginning to see maybe there's some bronchiectasis components there. But there's an emphysema predominant way, which is classic, which is what I've been taught for 50 years, that went this way. But that red curve was simply not described in my private, I started 50 years ago in medicine. That's not been described until this time. So I wanted to show you a couple of graphs from this, and then show you some bronchiectasis findings, and then raise questions. Gold zero, that stands for global obstructive lung disease, are the so-called normals. But remember, these were all heavy smokers. And what on the left side is 859 subjects in which the arrows show what happened to them over 5 years, how they changed. And you can just look at this, and I can't show you all of them, but some of the arrows are going this direction, getting better, but many of them are going this way in the prism. A few are going down, and a few are going this way. Now, you can't see 800 arrows. So I just took the worst 20. That's the top over this side. This is the people with the biggest change in their ability to breathe out over 5 years. And look at that. They come from the gold zero area, but most of them go this way into something that was never understood as part of lung disease, at least COPD. And a bunch of them go straight down to really severe disease down here. That was interesting. So then I looked at some other ones. I looked at the upper left quadrant, which wasn't thought to be chronic lung disease 10 years ago. These people show a lot of change. Again, it's striking that a few of them are getting better, and you can see the arrows here. Some of them are getting really worse very fast, but they're mainly dropping down into the this region of classic COPD. These are the top 20, so you can just see what they're doing. I'm particularly impressed that, what, 1, 2, 3, 4, 5, 6, 7, 8 out of the 20 are actually moving better. That gives us an indication that this disease is at least partially reversible. And some of them are getting a lot worse. And we need to understand what's driving this, what's enabling the previous one. Okay, so that's a big effort there. If you go on and look at the people who really have obstructive lung disease, this is what I call gold 2. That would be a 50, well, let's say 20 to 50% drop in their ability to breathe out with these arrows. And here there's almost 500 of them on top of them. And you can see that a few of them are getting better, but most are getting worse. And this is the top 20 of these. Again, kind of exciting that 1, 2, 3, 4, 5 got better, but disappointing that 15 showed a lot of progression. And so we're trying to figure out the ideal treatment to enable this and the ideal ways that we can create changes that do this. Now, this is COPD. Maybe some of you actually have that as well as the classic diagnosis of bronchiectasis. It's about 75–80% related to smoking, but it does occur without smoking, just as bronchiectasis does. So let me look. We started looking at the study and saying, what's going on with bronchiectasis? Now, remember I told you at the beginning that we excluded severe or known bronchiectasis at the time we did the study. So our group, this is actually done by Dr. Diaz, and he started using AI to look to see if anybody had early evidence of bronchiectasis. And to do this, he looked at the vascular system, which is shown, he looked first at the airway system, which is shown in blue on this graph, and then compared that to the size of the vascular system, which is shown in the red on this graph. And what he did was, look at this one right here, where the red line is bigger than the green line. The green is the airway, and the red is the corresponding vessel. That's classic and normal. If the airway starts to get bigger, it suggests it might be early bronchiectasis. So look down here. You see this green bar here? That's bigger than the red one underneath it. It's hard to see this with your eye. I can just point out 2 examples that are very obvious. If you look up here, the red bar is bigger than the green bar. So what they did is they used artificial intelligence to say which of these airways are actually bigger than the attending vessel that follows with it. And maybe that's what we'd call suspected bronchiectasis at the small airway level. That's different than the way it's diagnosed classically. It's classic diagnosed in big airways where you can see it on a chest X-ray easily. But this is looking at small airways that are part of COPD patients and saying, do you have evidence of airway dilatation of the small airways? Now they categorized the patients by this criteria, and they asked about the number of exacerbations they're having. An exacerbation means they're getting worse, which many of you experienced, and they've gone to their doctor and gotten a new prescription, or they've been admitted to an emergency room or a hospital. And they found the people that had this pattern of airway that suggested bronchiectasis had a substantial, significant increase in exacerbations. And that's what they reported 2 years ago here in radiology. So let me go on and just tell you another one or two, then we'll start answering questions. The same group, it's a large group of investigators in COPDGene, and Dr. Diaz is in Boston. But they determined bronchiectasis using AI. And their definition was a CT that shows the airway to artery ratio greater than 1. That's his criteria. Plus, they required that the people doing this have 2 of the following: cough, phlegm or sputum, shortness of breath or dyspnea, and have either had 2 or more exacerbations. And of that, they found that almost 18% of 7,662 COPD patients, or at risk of COPD, had what we call now suspected, not definite, but suspected bronchiectasis. And of those, almost 30% had died within 11 years. So they went on to say, let's correlate mortality in this and see what happens. This is their data. It's kind of interesting. This is people in normal spirometry. Remember, that's the right upper quadrant where they theoretically have a normal ability to breathe out. And they looked at the mortality curve. Suspected bronchiectasis is the hard line on top. And the rest of the same people in that same quadrant with COPD, or no, actually they wouldn't be diagnosed with COPD. They don't have a low capacity to breathe out. So they would be considered normal physiology, although they're heavy smokers and I don't consider them normal. But but if you compare their mortality on this line, it almost doubles if they had evidence of bronchiectatic changes, really suggesting that a big component of COPD is related to things that are going on with bronchiectasis, but at small airway levels that we need to understand and treat. That's never been known before. If you look at the PRISM quadrant, which is the one on the right, there's about a 25% increase of mortality for the people with suspected bronchiectasis compared to those without. And then if you look at the people that have classic COPD, we call it obstructive spirometry, there's maybe a 20% difference. But in every case, the presence of bronchiectatic changes suggests the need to intervene and treat. And so what I'm presenting here is the use of artificial intelligence to look at a massive database and find evidence, very early evidence for bronchiectasis in smokers that now need to learn from how we're treating bronchiectasis in the non-smoking population. We need to learn how to give those therapies to these people. And I don't know the exact numbers, but I would say that classic bronchiectasis, only 5 or 10% of people are smokers that have had COPD. This would apply to them as well. And so I really want to end by I want to show you some pictures. We're now doing this with we're having a team take all of our chest CTs, and there's about 25 or 30,000 of them, and look for airway wall thickness. The middle one is bronchiectatic changes in the small airways. And on the right side is mucus plugging. We're just beginning that. We've hired a really good radiology group to take all of our chest CT scans, and they're doing the first 1,000 scans to give us this kind of data. And I think we want to also do this on classic bronchiectasis patients, which is one of the next things we'll start looking at raising funds to do. It's interesting. I want to just show you what this is all done with AI, because you can't see any of the changes with your eye looking at this. They're too small and they're too complex. But if I want to take mucus plugging, and mucus plugging can also be a problem with bronchiectasis. You see the little red dots on the right side that have mucus plugs. Let me show you how that was done. This is the next slide right here. This is going with CT. Now, let me just see if I can start it. It's going with CT, starting at the bottom of the lung and creeping up, analyzing it with AI to see if there's evidence of a mucus plug. And you see 2 or 3 right here. Now, I'm going to let the program show you what the analysis by computer does as it goes up the lung, looking for more of these, and puts them on the graph to the right. I think it will go when I push it here. Let's see if I can make it go. I've got to make it go. Let's see. There we go. Now see, it's finding more and more as it goes up, and it's putting them on the right as it goes. This is all done by computer. And the end result is this for mucus plugs. I see us doing this for bronchiectasis very shortly as well. And the correlation will be is how does this small airway disease inform what's going on for either COPD patients or subjects with classic bronchiectasis? And how does that correlate with the bronchial wall thickening? Now, the classic COPD has what's on the right. They have thick, small airways. That's called bronchial wall thickness. That's the classic COPD. The one on the right is mucus plugging. And of course, bronchiectatic people actually have, instead of bronchial wall thickening, they have bronchial wall dilatation. So where can this all go? I think I'll probably skip these. These are what they're going to give us eventually, but this is the future of it. There are 2 new drugs that have been approved for COPD to stop inflammation in the past year. Now, they're not being used for bronchiectasis, but raised the question that you could use drugs like this or similar ones to treat complications of bronchiectasis. The two new drugs include Dupixent, which is really having a big, powerful change on people with COPD who have the right criteria to respond to that anti-inflammatory drug. But we need to define which pathways control progression, whether it's the airway disease, whether it's emphysema predominant, and we need to test these for drug development. And then we need to carry out clinical trials of large number of patients and find a way to either cure or stop the disease. And we need to focus on new endpoints, including inflammation, small airway disease, bronchiectasis, and mucus plugging. That's kind of where the whole COPDGene project is. It's a massive project, involves about 200 people across 20 universities. And I think it's going to help us understand both of these diseases. So what I'd like to do is just stop here and just open it for questions and tell you more about what I know about it. Remember that I'm not a bronchiectasis specialist, but I'm very interested in the interplay of how that disease correlates with COPD and how we might improve the care of both.
Thank you so much, Dr. Crapo, for an excellent presentation. It's really interesting to see AI and the bronchial pathways, and looking forward to so much more in the future.